First, I'd like to introduce myself. I'm Don Boudreau. I'm the manager of professional development here at the OPA. I'd like to thank everyone for taking the time to attend this evening's session, Demystifying Psychedelics, an overview for pharmacists. I'd also like to remind everyone of some of the methadone and opioid substitution resources that we do have available at the OPA. There's a number of online courses, discussion forums, there's the methadone toolkit, as well as the opioid substitution therapies information email, methadone@opatoday.com. And I'd also like to call out thanks for the support and funding from the Mental Health and Addiction Center of Excellence of Ontario Health for sponsoring this webinar. And with that, I'll pass it over to Candace.
Okay, hi everyone. I'm really happy to be here to talk about a little bit about just demystifying psychedelics and just to provide you with an overview. Lots to cover in this webinar, so I'm gonna, scratch the surface the best I can and just provide some resources where you could find more information near the end. I do have my email on the main page here as well, so I am happy to answer questions over email if they do come up for you after the fact. Okay, quick land acknowledgement. I'm based out of the Cowichan Valley on Vancouver Island, is actually where I live. So I do respectfully acknowledge that the beautiful land on which I do get to live and work is the unceded homelands of the Cowichan tribes. I would also like to acknowledge in this presentation that psychedelic plants and fungi have been used by Indigenous people since time immemorial and still play important cultural, medicinal, and healing roles. Indigenous people are key knowledge keepers when it comes to this type of medicine. So I don't, as Dom had previously said, I was a past employee of Numinous Wellness. I'm not currently, and I don't have any shares with the company. So this was a past relationship. I will be receiving a speaker fee for this webinar. And wanting to recognize that this webinar is supported by funding from the Mental Health and Addiction Center of Excellence of Ontario Health, to which I'm very grateful for. So by the end of this presentation, I'm hoping that you'll have an understanding of the mechanism of action of common psychedelics and be able to compare them to other commonly used psychotropics on the market. I want you to be able to summarize current research findings and have some awareness of some of the research going on around psychedelics related to psychiatric and substance use disorders, as well as discuss the role of the pharmacist in psychedelic-assisted therapy. So before we begin, why is this presentation important to you? So it's important to, political agendas aside, psychedelics are pharmacologically active drugs that are currently being both researched and used to treat a plethora of psychiatric and even physical conditions. Therefore, pharmacists need to be up to date, able to advise and educate on them, and ready to build them into their pharmaceutical care process. However, as it currently stands, psychedelics are not currently approved for medicinal use in Canada. Ketamine is the only exception, as it's currently approved to be prescribed under certain conditions for the treatment of treatment-resistant depression. All other psychedelics are currently regulated, well, I guess all psychedelics are currently regulated under the Controlled Drug and Substances Act in Canada, with MDMA and ketamine being scheduled under Schedule 1 of the Act, which means they're considered to have a high potential for abuse and dependency. And the other psychedelics such as psilocybin, LSD, mescaline, and DMT are listed under Schedule 3, which is considered to have a lower potential for abuse compared to Schedule 1 substances. So psychedelics can currently be accessed for medical use through Health Canada's Special Access Program, which means you may have patients accessing these medications and need to be informed and prepared to provide pharmaceutical care like we would with any other drug. So what are psychedelics? So psychedelics are also known as hallucinogens, and they're a class of psychoactive substances that produce changes in perception, mood, and cognitive processes. The name psychedelic is derived from the Greek words psyche, or soul or mind, and delaying, sorry, I pronounced it wrong, which means to manifest. So the meaning of it is mind manifesting. The implication being that psychedelics can develop unused potentials of the mind and be used to reveal the soul. That's kind of why they were originally named that. So hallucinogens or psychedelics fall into several different classes, broadly defined by their pharmacological mechanism of action and chemical structure. So classical psychedelics, these include the serotonin 2A receptor partial agonists, such as psilocybin, lysergic acid diethylamide or LSD, N,N-dimethyltryptamine, or DMT, which is the active ingredient in ayahuasca, and mescaline, which is also commonly called peyote. Entactogens are mixed serotonin and dopamine reuptake inhibitors and releasers, such as 3,4-methylene dioxymethamphetamine, or MDMA. Then there's dissociative anesthetics, which are N-methyl D-aspartate, or NMDA antagonists, such as ketamine and phencyclidine, or PCP. These are a little bit different in terms of how they work, but they definitely still have a hallucinogenic property to them. And then there's atypical hallucinogens such as ibogaine, which affects multiple neurotransmitter systems. I do have cannabis listed here as well. So cannabis obviously works differently, but at high enough doses, cannabis can have hallucinogenic properties. And interestingly, there are cannabis-assisted therapy studies actually being trialed right now in research with some positive effects, but the mechanism of action is obviously a bit different. Okay, so I'm going to spend a little bit of time on this slide just in terms of how psychedelics affect the brain. So there's a number of different mechanisms, and there's still so much being studied and learned about how psychedelics affect the brain. So this is what we know so far. So firstly, they impact various neurotransmitters in the brain. So psychedelics bind to serotonin 5-HT2A receptors, which alters the activity of serotonin, leading to a range of psychological effects such as altered perception, mood changes, and increased creativity. The impact of psychedelics on the serotonin system is complex and not yet fully understood, but research suggests that these substances can increase serotonin release and prolong the activity of serotonin in the brain. This prolonged activity may help explain the long-lasting effects of psychedelics even after a single dose. Similarly, certain psychedelics can increase dopamine in the brain, which can also have impact on mood and cognition. The next mechanism I want to highlight is a reduction in the activity of the default mode network. So in neuroscience, the default mode network is a large-scale brain network, also referred to as the medial frontoparietal network. It's best known for being active when a person is not focused on the outside world and the brain is at a wakeful rest, such as when you're daydreaming or mind wandering. Other times the DMN is active include when the individual is thinking about others, thinking about yourself, or ruminating about the past or worrying about the future. So research has shown that psychedelics reduce the activity of the default mode network, leading to a decrease in what we call self-referential thinking, so kind of that I or me that we run narratives about all day long. The reduction of default mode network activity is thought to be related to the altered state of consciousness that are often reported during psychedelic experiences. This altered state can lead to the sense of what we call ego dissolution, where a sense of self is temporarily lost, or more dramatically, people will talk about ego death, where the experience, this sense of self kind of dying. So by reducing this activity, psychedelics may be able to help individuals break free from negative thought patterns and behaviors, leading to improved mental health outcomes. Psychedelics have also been shown to increase neuroplasticity. So neuroplasticity is the brain's ability to adapt and change in response to new experiences. Recent research has shown that psychedelics can have a profound effect on neuroplasticity by increasing the growth of new brain cells and promoting the formation of new neural connections. This mechanism can also help individuals break free from negative thought patterns and behaviors. So if you see this image here, the brain on the right is basically what it looks like when psilocybin is in the system. So you can see a dramatic increase in the connections. So these are all neural connections. So a dramatic increase in the connections that may have previously been cleaved off due to lack of use. So with the brain on the left being without psilocybin in the system. So I like to describe this neuroplasticity using a metaphor of skiing or sledding down a hill of snow. So think about our brains as a hill that's been used all winter long. In this case, our whole life, right? So there's deep grooves and pathways of snow carved into the snow that we use over and over because it's easier to go down those paths than to create new ones in fresh snow. However, in our brains, if these paths are negative thought patterns and behaviors, this isn't beneficial and can lead to states of mind conducive to depression, anxiety, OCD, and addiction. Now, picture psychedelics as a fresh sheet of snow or shaking up the snow globe. We can create new pathways and leave old pathways behind. So for many, this is essentially what they do. Individuals are able to see things from a new or different perspective, which can be very healing. Some research has also shown that psychedelics can increase levels of brain-derived neurotrophic factor, or BDNF. BNDF in certain regions of the brain. Increased BDNF may also play a role in increased neuroplasticity. Lastly, brain imaging after the administration of MDMA has shown a decrease in amygdala activation and reduced fear response. So for an individual with PTSD, the amygdala is very overactive. So this kind of brain state makes therapy extremely difficult. But under the influence of MDMA, individuals become less fearful as the amygdala relaxes. MDMA also causes a release of oxytocin, which may also contribute to MDMA's emotional effects, but research is a little bit unclear about this still. So overall, through these mechanisms, we see a disruption in negative thought patterns and enhanced empathy and connectedness to oneself, with one another, and also with the environment. So I just want to take a second to show you the chemical structure of a few psychedelics. So you can see here that the chemical structure of psilocybin and LSD on the right is actually very similar to serotonin on the left here. So they all share this tryptamine molecule, which is outlined in red, consistent across all three structures. So this similarity allows psilocybin and LSD, as well as other classical psychedelics, to bind to and activate serotonin receptors in the brain, leading to its psychoactive effects. I also want to introduce the concept of psychedelic assisted psychotherapy, because a lot of what I'll be talking about and the vast majority of all clinical trials are using psychedelics in the context of psychotherapy and not just on their own. So what is this? So psychedelic assisted therapy is a form of therapy that involves using psychedelic substances to enhance the therapeutic process. So the therapy itself is actually the cornerstone of the treatment, but they're using a psychedelic to enhance that process. So this involves the use of psychedelics in a controlled setting under the guidance of usually one or two trained therapists. And the goal of psychedelic assisted therapy is to facilitate deeper emotional exploration and healing by creating a supportive and safe environment that allows patients to explore their thoughts and emotions in a more profound way than traditional talk therapy alone. During a psychedelic assisted therapy session, the therapist may use a variety of techniques such as mindfulness practices, breathing exercises, or somatic experiencing to help the patient stay grounded and navigate difficult emotions that may arise during the session. When discussing psychedelic assisted therapy, it's important to highlight the concept of set and setting, which was coined back in the 1950s. So set and setting refers to the mindset and physical environment in which the therapy takes place and can significantly impact the therapeutic experience. So set refers to the mindset and refers to the mindset, expectations, and emotional state of the person receiving the therapy. So set can also include the patient's expectations and intentions for the therapy, which are usually discussed in one or more preparatory sessions before the medicine is given. Setting, on the other hand, refers to the physical environment in which the therapy takes place. So it includes the physical space, the presence and behavior of the therapist, and any other factors that may impact the patient's experience. So a supportive and safe setting is important to minimize the risk of adverse reactions and ensure a positive therapeutic experience. Typically, individuals are laying down with a sleeping mask on to allow them to go inwards as needed, and they're usually listening to music specifically curated for a psychedelic experience, which is usually classical music without words. Following the medicine session, one or more integration sessions should always occur to help the patient process and integrate what came up during the session. So before we dive into the specific psychedelics, I just want to talk a little bit about psychedelic research, which has a really rich history. So many psychedelics were identified or synthesized well before research actually began on them. It's kind of like cannabis, if that feels familiar. Psilocybin mushrooms have been around for millennia, and MDMA was first manufactured in 1914. LSD was first synthesized in 1938, and its psychedelic properties were really discovered in 1943, which really marked the beginning of scientific exploration into these compounds. So in the 1950s and 60s, psychedelics were actually extensively studied for their potential therapeutic applications, particularly in psychiatry. This period saw over 1,000 clinical papers discussing 40,000 patients receiving various forms of psychedelics for issues ranging from depression, schizophrenia, and alcohol addiction to the enhancement of creativity and self-awareness. So the pioneering work of individuals like Dr. Alexander Shulgin, so seen in his lab here in this image, who synthesized and documented the effects of over 230 psychoactive compounds, including MDMA, was crucial. So his work, particularly the characterization of MDMA's effects, laid the groundwork for future studies. Now, the way he went about it wasn't necessarily up to par with ethical standards, because he would often experiment these substances on his family and friends, wife. It was very unethical back in that day, but he documented and really discovered a lot about these substances. Then in 1970s, President Nixon declared a war on drugs and essentially shut down all research related to psychedelic drugs. So psychedelic drugs were then deemed drugs of abuse with no medical purpose, despite all the evidence proven to contradict this up until this point. Psychedelics became classified as a Schedule I substance in the US and regulated, as previously mentioned, in Canada, which significantly restricted and basically shut down its research. So research resurgence began cautiously in the early 2000s, with new studies exploring the therapeutic potential of psychedelics in more controlled clinical settings. This resurgence was supported by improved understanding of their pharmacology, rigorous clinical methodologies, and a shift in public perception towards mental health treatment and recognizing that we need more treatment options. So I'm going to discuss the two psychedelics I'm going to really focus on in this presentation is psilocybin and MDMA, because those are the ones that are furthest along in the research and probably most commonly being used, and I expect will be the first to come to market if they do get to market. So for classical psychedelics, I'm going to talk about psilocybin, but many of the classical psychedelics are similar, like LSD, DMT or ayahuasca and mescaline. But there are small differences in their pharmacology and pharmacokinetics that exist just like with any other class of medication. Those other classical psychedelics are also being actively studied as well in research, but they're just not as far along as psilocybin. Okay, so psilocybin. So psilocybin is a naturally occurring compound produced by more than 200 species of mushrooms, collectively known as psilocybin mushrooms, or maybe more commonly known as magic mushrooms. You may have heard them referred to as that. The most potent are members of the genus Psilocybe, such as Psilocybe cubensis. Although psilocybin is studied in clinical trials is typically synthetic, the vast majority of the documented history of safe use has been derived from the consumption of psilocybin-containing mushrooms over thousands of years. And a lot of researchers and scientists actually believe that there may be some added benefits of the whole mushroom with the other compounds in there in addition to psilocybin, as opposed to just psilocybin on its own. But most of the research has been done with just isolated psilocybin, synthetically derived. So psilocybin is actually a prodrug that's quickly converted by the drug to psilocin, which is the psychoactive compound. It's most commonly consumed in the form of a tea, or it may be eaten whole or dried and crushed into capsules. Majority of clinical trials, as I said, use synthetic psilocybin in the form of a capsule. Its onset of action is actually quite fast, starting to work in about 10 to 40 minutes, and it lasts for about 2 to 6 hours. How it's consumed impacts this duration of action. So usually a tea starts working quite quickly and may wear off in a few hours because the psilocybin breaks down into psilocin in the hot water before consumption. So that can be a quicker way as opposed to orally ingesting them through like eating the mushrooms or through a capsule. The usual therapeutic dose of psilocybin can range from 10 to 50 milligrams. The most common studied is 25 milligrams, which is equivalent to about 2.5 grams of dried mushrooms, which is 25 grams of fresh mushrooms. The dose range can vary, like I said, and some clinical trials have used up to 60 milligrams, but they're finding that a higher dose isn't necessarily more beneficial, but does come with more adverse events. So they seem to be sticking around the 25 milligram range. And as I said before, psilocybin is a serotonin 2A partial agonist, which increases serotonin effects in the brain amongst the other effects discussed earlier. So how does psilocybin affect our body? So physically, psilocybin can cause acute effects such as pupil dilation, an increase or decrease in heart rate, and most commonly it's an increase and it's usually short-lived. As well as hypo or hypertension. And again, this is usually short-lived and tends to be more increased blood pressure acutely. Nausea, so this can be intense for some people, but often depends on how it's consumed. So eating whole mushrooms can be harder on the stomach than a tea. And some people do mix ginger into a tea to help with the nausea, but it definitely can be prevalent for people. Headache is also common and often occurs a day after treatment, but it doesn't usually last more than 24 hours and most often can be managed with over-the-counter pain relievers. After ingesting psilocybin, a wide range of subjective effects may be experienced, which can be perceived to be either positive or negative or both. So many experience what's considered a good trip, lending to feelings of insight, connectedness to others and nature, mystical experiences, and joy. It's also possible to experience a bad trip, which can lead to feelings of depression, anxiety, or paranoia. So set and setting is very important in this process. And when it's not taken in a controlled supportive setting, there's an increased risk of a negative experience. So I know a lot of people that I've talked to, often anecdotally describe having an awful experience, on mushrooms at some point in their life. But if you ask these people, most of them took way too high of a dose while at a party amongst, chaos, along with being used with other drugs or substances such as alcohol. So all of this goes into that setting, the set and setting, and this can increase the risk of kind of more of a negative experience. So interestingly, in clinical trials, even those who experience negative symptoms during a session in a controlled setting often report the session as being incredibly meaningful because sometimes they're able to get to the bottom of anxiety or things that they're worried about. So studies have found that following psilocybin use, many people report personality changes like increased openness to experience and connection to spirituality, which does not usually mean religion. It just means more spirituality, can be related to religion. Psilocybin also produces acute sensory effects that maybe some of you have heard of. This includes seeing like radiant colors and patterns as kind of the theme of some of the images I put into this presentation. If you see psychedelic art or things like that, it's often very like colorful and rainbows. There's an altered sense of time, so it can either be speeding up or slowing down, and overall very animated sensory experiences. So you may see music dancing behind your eyes or perceive the walls or the roof to be moving around you if your eyes are open. That's why sometimes it's better to have them closed with an eye mask on, to try to take away some of that overwhelm of the sensory perception. So psilocybin has been studied in clinical trials for a number of different indications. I'm going to focus on a few in this presentation, including end-of-life distress, depression, and substance use disorders. But please know there's many more indications being studied with positive success so far, including OCD, bipolar depression, Parkinson's, eating disorders, cluster headaches, and migraines, and probably many more that I'm not even listing here. So for end-of-life distress, I want to highlight the following study by Dr. Stephen Ross and his team out of NYU. So they conducted a double-blind, placebo-controlled crossover trial in 2016 to investigate the effects of a single administration of 0.3 milligrams per kilogram versus placebo, which was niacin, in conjunction with psychotherapy to treat cancer-related anxiety and depression in 29 individuals with terminal cancer. So most of these doses equate to usually around 25 to 30 milligrams of psilocybin. They've stopped dosing it by weight now. They used to do it a lot by weight, and now it's usually just kind of 25 milligrams or 30 is a really standard dose. Following a session with psilocybin, participants reported decreased hopelessness associated with cancer and improved spiritual well-being and quality of life 1 day and 7 weeks post-dosing. More specifically, 7 weeks after dose, 83% of participants in the psilocybin group met the criteria for depression response and 58% for anxiety response, compared with 14% for both in the placebo group. And this was statistically significant. At the 6.5-month follow-up, after both groups received psilocybin because it was a crossover trial, antidepressant and anxiolytic effects or rates were approximately 60 to 80%, which remains statistically significant. Interestingly, 70% of participants rated the experience as a single or top 5 most personally meaningful experiences of their entire lives. So next, I'm going to highlight one of the depression trials. So the majority of trials have been focused on treatment-resistant depression so far. So that's what I'm going to talk about. So the largest randomized controlled trial to date is the COMP 360 psilocybin phase 2b trial that was published in the New England Journal of Medicine in 2022. Compass Pathways is now moving forward with their phase 3 clinical trials for this indication to be able to submit it for approval from the FDA. So this pivotal study was conducted across 22 sites in 10 countries involving 233 adults with treatment-resistant depression. This was a randomized, double-blind, placebo-controlled trial designed to assess the efficacy of psilocybin in treating depression over a period extending up to 12 weeks post-treatment. In this trial, participants received a single dose of psilocybin, so either 25 milligrams, which they called high dose, 10 milligrams low dose, or 1 milligram, which was the placebo. Psychological support was provided to participants before, during, and after each session, so this was considered psilocybin-assisted therapy. So at the 3-week mark, the results were quite significant. The 25 milligram group, experienced a reduction of depression symptoms by 12 points on the Montgomery-Åsberg Depression Rating Scale, compared to 4 points in the placebo group, which was statistically significant. And at 12 weeks post-treatment, 29% of the participants in the 25 milligram group maintained a sustained response to the treatment, compared to only 9% in the placebo group, also statistically significant. So this data demonstrates an enduring benefit of psilocybin in treating depression even after 1 dose. Common side effects includes headache, nausea, and transient anxiety. Although serious adverse events were rare, they did include a few instances of suicidal ideation, highlighting the need for careful monitoring of all participants throughout the study duration. I thought it would also be interesting for you to be able to point out to a study that directly compared psilocybin to escitalopram for the treatment of moderate to severe depression, so you can see how it held up compared to a very commonly used antidepressant. So this was published in the New England Journal of Medicine in 2021 by Dr. Robert Carhart Harris and his team out of Imperial College London. So in this phase 2 double-blind RCT, 59 participants with long-standing moderate to severe depression were given either 2 doses, separate doses of psilocybin, 25 milligrams, 3 weeks apart, plus 6 weeks of daily placebo, or 2 separate doses of 1 milligram psilocybin, 3 weeks apart, plus 6 weeks of escitalopram, 20 milligrams. All the patients also received psychological support throughout the trial. So a response to treatment, defined as 50% reduction in depression symptoms, occurred at week 6 in 70% of the psilocybin participants, while only 48% of the escitalopram participants. And likewise, a full treatment remission, defined as no longer meeting the diagnostic criteria for depression, was seen in 57% of the psilocybin group and only in 28% of the escitalopram group. So these results were all statistically significant, and adverse events were actually similar between groups. So I find these results impressive, but it would be helpful to see a longer trial because 6 weeks is maybe not enough time for the escitalopram to exhibit its full effects, especially for remission, which can take up to 13 weeks. So I'd like to see that repeated, but for a longer period of time. It is interesting initial results, though. So psilocybin's also been showing really good effects in individuals with various substance use disorders. So I'm going to highlight studies on alcohol use disorder and tobacco use, but other studies have been looking at opioids and other substances as well. So the first studies for tobacco addiction. So Dr. Matt Johnson and his team out of Johns Hopkins University have conducted a number of studies looking at this, with more coming down the pipeline. So this was an open label pilot study administering psilocybin doses ranging from 20 to 30 milligrams per 70 kilograms of body weight within a structured 15-week smoking cessation treatment protocol, including cognitive behavioral therapy. So participants were 15 psychiatrically healthy, nicotine-dependent smokers with a mean of 6 previous lifetime quit attempts and smoking an average of 19 cigarettes per day for a mean of 31 years. Hannah, I see your question. I'll get to it in just a sec here. So the combination of the psilocybin with the treatment protocol demonstrated prolonged success. So with 80% of the participants reporting abstinence and 73% biologically confirmed to have quit smoking at 6-month follow-up. So those that did not quit smoking had to reduce their daily cigarette use. And at 1-year follow-up, 67% of them were still abstinent from smoking, and 87 reported, again, psilocybin as being a very meaningful experience in their life. When we compare this to commonly used treatment approaches available today, it's quite astounding. So nicotine replacement therapy has an average quit rate around 10 to 15% at 6 months. Varenicline is around 28% at 12 weeks, and bupropion around 23% at 12 weeks. So this is definitely a small open label study, but we did see more than, they saw more than double the abstinence rates from 2 medicine sessions with psilocybin plus cognitive behavioral therapy. So, in collaboration with other institutions, this team has already initiated a multi-site double-blind RCT to study this at a more rigorous level. So, the results they should be coming out in the next couple years. If not, I'm not sure if it'll be a full couple years, but they're currently running this trial right now. So, Hannah, I see you have a question here. You say studies have shown therapeutic uses are statistically significant. Are they also therapeutically significant? So, I would say yes, based on the results that I've seen. I think the rates of response and remission are impressive. I'd say a reduction or a difference in the Montgomery-Åsberg depression rating of 8 points is significant enough, in my opinion. You all might feel, some of you might feel differently. But I do think that they are clinically significant in my opinion, but that's a really good question and always something to be considered when we're looking at these studies. It'll be interesting to see what they come out with their phase 3 trials for depression, because that was their phase 2. So they'll have 2 back-to-back phase 3 trials with larger groups of participants. So it'll be interesting to see how that statistical and clinical relevance shows up. So the next study is for alcohol use disorder. So this trial was published in JAMA Psychiatry in 2022 by Dr. Michael Bogenschutz and his team, again, out of NYU. So in this double-blind randomized controlled trial, there was 95 participants offered 12 weeks of psychotherapy, including motivational enhancement therapy and cognitive behavioral therapy, and were randomly assigned to receive either psilocybin or diphenhydramine, which was the active placebo, during 2 medication sessions at weeks 4 and 8. So psilocybin was dosed at 25 milligrams per 70 kilograms at the first session, and then there was the option of increasing up to 40 milligrams per 70 kilograms at the second session. So what was found is the percentage of heavy drinking days during the 32-week follow-up period was significantly lower in the psilocybin group, so 9.7% compared to 23.7% in the diphenhydramine group. And the mean daily alcohol consumption was also lower in the psilocybin group. There was no serious adverse events amongst participants who received psilocybin. So a number of phase 2 trials, have begun looking at this in more in depth, even in Canada. So researchers at Queen's University, Kingston Health Science Centre, as well as the University of Calgary, their School of Medicine, are all looking at this. And the Canadian government has actually invested $3 million to support 3 clinical trials examining psilocybin-assisted therapy for potential treatment for various conditions, including alcohol use disorder. So these trials are at various stages of development and implementation. So it'll be interesting to see what further results. So these are all very early stage trials, but still interesting and really impressive results, in my opinion, but more data to come for sure. So we're going to move on to entactogens, or MDMA. So MDMA is a prototypical example of an entactogen. So I'm going to discuss that in the next few slides. So I'm sure many of you are familiar with MDMA as being what is the active ingredient in ecstasy, often used as a recreational drug in the clubs and especially for events like raves. So ecstasy is often called the love drug because it heightens the perceptions of color and sound and amplifies sensations when one touches one another. However, it's important to also know that ecstasy you buy on the street is rarely contains pure MDMA, and it's often laced with many other stimulants or illegal stimulants like amphetamines. So MDMA is actually a semi-synthetic compound that can be derived from different essential oils of plants such as sassafras, saffron, dill. MDMA was first synthesized actually by Merck Pharmaceuticals and patented in 1914. And it was synthesized originally as a larger effort to develop medications that could stop bleeding. So MDMA is structurally similar to, it's really unique because it's structurally similar to both methamphetamine and another psychedelic called mescaline or peyote. So you can see here in this image, so MDMA being on the bottom right, amphetamine above, mescaline top left, and then methamphetamine on the bottom left, that they share a lot of properties. So they all share this basic phenethylamine backbone. That you can kind of see, they all kind of have that backbone with a benzene ring leading off. But you can see that MDMA shares similarities on the right side of the benzene ring to amphetamine and methamphetamine, but then it shares similarities on the left side to mescaline. So it really has this unique effect of being a blend between amphetamines, which are stimulants, and mescaline, which is a psychedelic. So that's kind of the stimulant feature of MDMA is what differs it from other psychedelics like psilocybin, LSD, ayahuasca, and mescaline. MDMA is administered orally in clinical trials. This is usually a capsule, and its onset of action is pretty similar to psilocybin with a slightly longer onset. So it takes about 30 to 60 minutes to start working and lasts for about 3 to 6 hours. So you can see in this graph is kind of like a really quick rise up and then kind of a slow taper off. In clinical trials, we tend to see supplemental doses given after a few hours to extend the duration of action to allow a longer, more productive therapy session. So usual doses for therapeutic purposes is 80 to 120 milligrams, and then a supplementary dose of 40 to 60 milligrams might be given after a few hours. Pharmacologically, MDMA is a potent reuptake inhibitor of serotonin, dopamine, and noradrenaline compared to psilocybin, which is a serotonin partial agonist. This is why it also has, again, stimulant-like effects and feelings of increased energy and pleasure compared to the other psychedelics. So many of the physical effects of MDMA are similar to psilocybin, such as increased heart rate and blood pressure, acutely nausea, headache. But some of the other effects we do see from MDMA specifically include teeth clenching, muscle tension, and potential for hypothermia. So MDMA can affect the body's ability to regulate temperature, leading to feelings of warmth, sweating, or chills. So we need to closely monitor body temperature during medicine sessions. At raves, this can be potentially dangerous due to all the dancing, the hot temperatures, a lack of fluid intake. So you'll often see cool down and water stations, set up around raves. But in a clinical setting, we find these risks minimal because we can really, if we see someone's temperature going up, we can take off blankets, we can give them an ice pack, we can do things like that to help. Psychologically, what we see with MDMA is increased feelings of connectedness and closeness with others. We also see reduced anxiety and fear because of that amygdala response reduction. This really helps aid the therapeutic alliance and process. So MDMA is not typically associated with a bad trip that can occur with other substances such as LSD or psilocybin, but it is possible to have negative experiences with MDMA, especially at higher doses or in certain contexts. So this may include kind of similar anxiety, panic attacks, paranoia, agitation, or aggression. Sensory effects from MDMA share similarities with psilocybin, but what we really see at the forefront is enhanced physical sensations, such as touch, increased pleasure derived from physical contact. So, as you can imagine, there needs to be a strong code of ethics in place during MDMA-assisted therapy sessions to ensure that any touch used for comfort during therapy sessions are agreed upon and consented by the patient before MDMA is actually taken. So MDMA assisted therapy, because MDMA has that stimulant component, the MDMA assisted therapy can look a little bit different than other psychedelic assisted therapy. So as the medicine begins to take effect, a really unique like therapeutic environment becomes available, allowing individuals to explore traumatic experiences and deeply rooted emotional issues. Um, so they may spend time with eye shades and headphones on, but they may also spend time actively engaging with a therapist. So it becomes sort of this inward and active experience. So actively, they may actually, talk to the therapist, discuss their experience, feelings, and insights. It can foster this sense of trust and connection, which can enhance that therapeutic alliance. And especially in people with PTSD, that can be really helpful because it's often there's a lot of fear and unwillingness to be able to an inability to talk about some of those things. They may also have like a strong emotional release. So you may see like crying, anger, even laughter. And this emotional release can be very therapeutic, especially when guided and supported by trained professionals. And some people can also have heightened body awareness, which can be also important for trauma that might be stored in the body or somatic symptoms. So while MDMA is being trialed for a number of different indications, just like psilocybin, the most data by far comes from its research around post-traumatic stress disorder. So as you know, PTSD is a common debilitating condition with immeasurable social and economic costs that I think we're having more and more awareness around that affects the lives of hundreds of millions of people a year. So SSRIs, sertraline and paroxetine are first-line medications for the treatment of PTSD, but it has been found that 40 to 60% of patients don't respond to these medications, and many participants fail to respond to trauma-focused psychotherapy approaches alone. So MAPS, now Lykos Therapeutics in the US, has been spearheading this research for a number of years and has brought it furthest along than any psychedelic to date. So this is the first phase 3 trial of the 2 studies needed to apply for a new drug application to the FDA. It was completed by Dr. Jennifer Mitchell and others and published in Nature Medicine in 2021. So overall, 131 participants with severe PTSD were enrolled across the United States, Canada, and Israel. And participants were treated with 3 sessions of MDMA-assisted psychotherapy, along with integrative psychotherapy between sessions and following. So you can see here that the MDMA-assisted therapy in the red reduced the CAPS-5 PTSD scores by a much greater percentage than placebo, especially after the 3rd session in particular. So the effect size was seen to be 2.1 compared to 1.2 in the placebo group, which was, again, statistically significant. More impressively, 67% of participants, I think this is, really highlights 67% of the participants no longer met the diagnostic criteria for PTSD following this treatment, compared to 32% of those in the placebo group. So this was an impact of more than double. The results of the second pivotal phase 3 clinical trial were just published in Nature Medicine last year. So 104 participants were randomized to either MDMA-assisted therapy or placebo, with still the assisted therapy component. And what we saw was a least squares mean change in CAPS-5 scores by 23.7 points in the MDMA group in red, compared to 14.8 in the placebo group. This amounted to an effect size of 0.7, so this was smaller than the first study, but still significant. They also found significant reductions in the Sheehan Disability Scale scores as well. There were no deaths or serious adverse events. No reports of MDMA abuse, misuse, physical dependence, or diversion were reported. So Lykos is currently in back and forth discussions with the FDA around their new drug application they submitted, and it seems that FDA is going to want more studies before approving it or bringing it to the market for PTSD. Okay, so let's dig a little bit more into some of the other safety considerations like abuse potential, toxicity, and drug interactions, because we are pharmacists and we do need to think about all of those things. So there are a lot of concerns about toxicity and abuse potential of psychedelics. Psychedelics actually have a relatively low abuse potential, and this is for a few reasons. So first, they haven't been shown to cause any physical dependence or withdrawal, which is 2 key factors associated with abuse. And psychedelics also elicit really introspective, mystical, spiritually meaningful effects compared to intense pleasure or euphoria. So while MDMA does have some of that, it has a psychedelic component too, which seems to limit this risk. Most people need time to actually recover after a strong psychedelic experience, and the thought of doing it again can be quite overwhelming depending on what comes up for them. Lastly, it's been found that repeated use of psychedelics over several days may actually reduce the effect of them. This likely has to do with a rapid down-regulation of serotonin receptors following the use that need a few days to regenerate. So since someone can't rapidly experience the same effect day after day, this really kind of curbs that risk of addiction. As for toxicity, it's actually a lot lower than other commonly used substances like alcohol and tobacco. And the lethal dose of psilocybin is actually less than OTC drugs like aspirin. But as such, the overdose risk is low, but like any substance, too high of a dose can definitely be toxic and increase the risk of adverse effects. Given MDMA's effect on regulating body temperature and sweating, high doses or unsupervised dosing does have the potential to lead to serious effects like heart or kidney failure. So in a supervised setting, participants are screened and carefully monitored, but MDMA does carry a slightly higher risk than other psychedelics because of this stimulant part of it. It should always be used under the supervision of medical professionals, which is what the research is advocating for. And it's also important to note that all psychedelics do have the potential for psychological distress or adverse reactions, as I mentioned. So again, this is highest when used in unsupervised or uncontrolled settings. These adverse reactions can include panic attacks, feelings of extreme anxiety, paranoia, or even psychotic episodes. We are very cautious in individuals with a history or family history of psychosis or mania, as well as those with borderline personality disorder, because they're at higher risk for psychological distress as well, and higher risk of psychosis. So I'm sure more research is going to be done, but currently we exclude anybody with these conditions or history from clinical trials at this point. In addition, there is some evidence to suggest that the use of certain psychedelics, particularly high doses of LSD, can lead to prolonged changes in mood or cognition, such as persistent changes in visual perception, anxiety, or depression. But these risks are quite low and have not been found in any recent clinical trial to date. So it's often a fear, but it hasn't been demonstrated in the research currently in a controlled, supervised setting. Drug interactions. So I'd say what we know about drug interactions with psychedelics is still quite limited. It's likely going to look a lot like cannabis, where they're going to get legalized and then we'll be scrambling to find the answers. But let's review what we know so far. So psychedelics interact with antidepressants, especially those that affect serotonin. So two things can happen. First, there's a risk of serotonin syndrome due to an increased risk of serotonin by both drugs. Many people use both anecdotally and are fine, but the risk is definitely there. The risk is really high with ayahuasca. We haven't really discussed it, but essentially ayahuasca is DMT, which is a classical psychedelic, mixed with another plant that actually acts as a monoamine oxidase inhibitor. So because of this, serotonin doesn't get broken down and the risk of serotonin syndrome is very high. So this is important to note in case any of your patients come to you talking about going to an ayahuasca ceremony of any sort. The other thing we see is a reduced psychedelic effect when taken by someone who's also on an antidepressant. So this is because many antidepressants work by increasing the concentration of serotonin in the brain and inhibit its reuptake, which can lead to this downregulation of serotonin receptors over time. So since many psychedelics work by stimulating serotonin receptors, this downregulation can reduce in a blunted effect of the psychedelic. So some people get around this by taking a higher psychedelic dose, but this isn't supported by research. Interestingly, a recent clinical trial explored this impact by administering psilocybin to those taking escitalopram, and no impact on psychedelic effect was seen. But the participants only took escitalopram for 7 days, and this, in my opinion, this likely wasn't enough time to see serotonin receptor downregulation. For antipsychotics, you can still see the blunted psychedelic effect as discussed just now with antidepressants. And the combination of psychedelics with antipsychotics can also increase the risk of adverse effects, such as acute psychosis and other psychiatric symptoms. So this interaction is likely due to the fact that antipsychotic medications work by blocking dopamine receptors in the brain, while some psychedelics work by stimulating these same receptors. So there's a little bit of it's a little bit counterproductive in that sense. And of course, as pharmacists, we're always on alert for CYP interactions. So these do exist with psychedelics, but majority are substrates of CYP, and they're not necessarily inhibitors or inducers that we know of. Psilocybin, MDMA, and ayahuasca are all metabolized by CYP2D6, and MDMA is also metabolized by CYP3A4. Lastly, many psychedelics have the potential to prolong the QT interval. So in clinical trials, all participants get a baseline ECG to assess their cardiovascular risk. So this would be an important consideration for those with QT risk, significant cardiovascular history, or other medications that could increase the QT interval. Okay, so where do pharmacists fit in? So you may already be fielding questions from the public about these medications. It's important that you're able to provide evidence-informed answers and be aware of what evidence is known to date. So psychedelics are drugs, therefore we do need to and should be involved in the discussion. We are the medication experts, and this is just another class of medication. I know it feels like a lot because of all the assisted therapy, but at the end of the day, the medication itself is just a medication. And we have other health professionals involved in the assisted therapy component. So when done right, we can be one part of a very involved and supportive team for patients. So this may involve helping screen for contraindications and drug interactions, providing patient education, or monitoring for side effects following treatment. If patients are interested in this type of treatment, you can help refer them to reputable clinics, what we call like above ground, offering services through the special access program. I would definitely caution away from clinics who seem to be pumping people through without careful supervision and integration. So if you don't see a lot of preparatory and integration sessions and things like that, that would be a word of caution for these types of clinics. And what kind of patients might you see looking for this? So you might see patients with treatment-resistant conditions who have not had success with other treatment options. So often this might be a last resort, and for some it could be a very successful last resort. You see people who have stories of not getting approval for it, and they're applying for MAID and they get approved for MAID, but they don't get approved for these treatment options. So for a lot of people, this could very much be a last resort. You may see interest from patients who are interested in the other mechanisms by which psychedelics work. So the neuroplasticity and the processing, the deep processing of past trauma. You may also see interest from individuals who have used psychedelics recreationally in the past. So, when approached by patients about psychedelics, I'd say it's really important to enter the conversation with curiosity and without judgment. We rarely know the experiences someone has faced over their lifetime and what has led them to being interested to ask or asking for your help. So, don't ever make assumptions that someone's just trying to look for a legal drug access. Remember that psychedelics are psychoactive drugs with a decent amount of evidence for their medical use so far. Try to learn why they're asking for it and what they already know, as many people have done their own research. It's a really great opportunity to clarify misconceptions and provide teachable information. And lastly, again, be prepared to know what kind of reputable clinics offer this service in your area so you can refer patients for further information. I do have a few helpful resources here. So MAPS, which is the Multidisciplinary Association for Psychedelic Studies, and MAPS Canada. I have the two websites there. They do post a lot of like publications, blogs, webinars, and education for those who are interested. Lykos Therapeutics, it kind of was a branch that came off of MAPS. They are the ones who ran the phase 3 clinical trials for MDMA. It is a drug company, but it does have a lot of good educational material and research materials on psychedelics and MDMA assisted therapy, but obviously know that, they are a drug company as well. Um, Dr. Benjamin Malcolm, he runs a company called the Spirit Pharmacist in the US, and he is a PharmD and specializes in psychopharmacology and psychedelics. He has both free and paid webinars and educational materials that are really pharmacist focused, and he's quite good. He's quite lovely. So he runs a consulting business, and could be a resource. He does have some free webinars, as I said. And if you haven't already read the book, How to Change Your Mind by by Michael Pollan, this book is a good way for learning kind of about the history and how psychedelics work. I think that the book is much better and way better for learning than the Netflix series, but the Netflix series is there as well. Um, I don't want to list any clinics because they change all the time. And I think that they really need our critical eye to assess the information. So I don't want to list some clinics and then have the quality of those clinics change. So you need to kind of be familiar with what's available in your area. So that was a lot of information. In summary, psychedelics are a promising new but old area of research for a number of mental health and physical disorders. We didn't really dig into the physical conditions, but you can find the research out there. Legalization is potentially around the corner, so it's time we do prepare for what this means for pharmacy practice. More research is certainly needed, so stay tuned, especially when it comes to things like drug interactions. I do think we're going to play an important role. And yeah, I hope you enjoyed this overview. I'm happy to answer questions now and by email as well. Thank you. I also have my references listed at the end for if anybody wants to go into those after. Okay, so I'm going to stop my share there. And I see the Q&A here. So if you want me just to jump into the Q&A, so you mentioned studies with psilocybin for PTSD and MDMA for depression. So other way around, psilocybin for depression, MDMA for PTSD. Any treatment recommendations for a patient with both depression and PTSD? Interesting. I mean, obviously clinical trials have to study people in like a very isolated setting to try to reduce as much confounding as possible. So I think a lot of people with PTSD also have symptoms of depression and also vice versa. So I would say, in terms of whether they could be treated with something like this, I would say, again, they would need to get assessed by a medical, like a doctor or a psychiatrist, to see if they could qualify for the special access program. Currently, of course, there's medications out there and there's psychotherapy and things like that, which are, really important cornerstones of treatment. But when it comes to psychedelics, it would depend on the overlap between the two and whether it would be a good fit for them or not. I know that doesn't really answer your question completely, but at this point, there's no trials looking at both, but there's certainly positive trials for either. I would say that they likely wouldn't do, thinking of it, someone with PTSD, they'd probably go the MDMA route and see if it would target both the PTSD and the depression before then going down like a psilocybin route. So they'd probably start with one and see the effect. I think what we're going to see with psychedelics is like they're all going to be very similar, just like we have different classes of antidepressants. And then you kind of target certain ones based on the symptom profile or the patient's, personal experience. Do they have a lot of trauma? Is there a lot of fear? You kind of go into it that way. How do we get our patients access while we wait for government approval? Yeah, so the best way to go about that is to, and I'll be interested actually if pharmacists start to get asked to be part of special access applications because they are quite lengthy. And I know there are some pharmacists who are actively kind of collaborating with medical clinics to help in this process. But I would say the couple things that you could do is first and foremost, I didn't talk a lot about ketamine. Ketamine is a dissociative anesthetic. It's not exactly a psychedelic, but it does have hallucinogenic properties. And there's a lot of clinics right now using ketamine assisted therapy like they would other psychedelics because they can actually access it and they don't have the time delays of special access. On Vancouver Island here, we have a group called Roots to Thrive, and there's a few other ones using ketamine, and seeing really positive results as well for things like PTSD, depression, anxiety. And so I'd say that that could be something that patients can initially look at is whether, and there's actually less drug interactions with ketamine. So a lot of people can stay on their current medications and have the ketamine therapy, whereas a lot of these other treatments, you have to often take them off their treatment before you give them the other psychedelic. So that could be something to look into for now for a lot of individuals. The other thing would be to refer them to a doctor or a medical clinic that offers this service, and they could get screened to see if they would qualify for special access. I wouldn't recommend, of course, people can access these medications like underground and through like ways that aren't through Health Canada. As pharmacists, I don't think it's our job to be making those recommendations or to be going that route. So I would say stick above ground, stick to clinics that are offering this, doctors, and looking into clinics that offer that ketamine assisted therapy. But again, I'd really advocate for referring or being aware of clinics in your area that have the whole therapy supportive component in addition to the ketamine. And there are some that are just pumping people through ketamine. And I think that there could be some benefits to just ketamine, but I think the assisted therapy is a really important component of psychedelic assisted therapy. So I would kind of be familiar with what you have in your area. But it can be a long wait for special access. And as I said, like people are getting approved for MAID before they're getting approval for some of this, but I think it has picked up a bit. I think there was a big backlog, and I think the government is picking up the pace now with some of these applications. Okay, I'm not seeing any other questions, but I'm happy to take more.
Actually, a couple more.
Oh, there's more. Oh, sorry, I didn't scroll down.
Yeah,
Sorry about that.
how much is the cost of therapy?
Oh, yeah. So, good question. So it depends. So right now, some of the drug companies are offering the drug for special access, like not for a significant amount of money. I'd say that you're looking at probably anywhere from $2,000 to $6,000 for a course of treatment. Now that includes the drug is like, so you think about a therapist, right? A therapist is like $180 an hour for a trained therapist. So if you're thinking about the fact that they're with them for potentially 6 hours during a medicine session, you're going to do 2 or 3 of those, plus the integration, the prep, the doctors that have to do the screening, plus the drug, it adds up. So I think that, some people's benefits can, so I see a question here about funding. So I'd say benefits might be able to cover some of it, like around the actual, if you have therapist hours or if they're, registered therapists, you might be able to get some of that covered. I know some employers, like for firefighters or some even Indigenous tribes, are actually sending patients to clinics with funding for some of these conditions as well. So I'd say, but if you're paying out of pocket, you're probably looking at right now at about $2,000 to $6,000, depending on how extensive the therapy component is. Which some people, it's like that's totally inaccessible, and for other people, they're sort of willing to do anything. You know what I mean? So it depends on kind of where they're at and what they can afford. But, if you do have populations of who are Indigenous, you should look into they should look into their tribes and see if they can get support. And then you could also look into like employer benefits as well. Do I know of any publicly funded clinics? I'd say that they're mostly private right now. I think that there are, public clinics who are definitely offering ketamine, but maybe not in the full ketamine assisted therapy component. It might just be more like the intranasal ketamine or injection. So I'd say that they're mostly private, and that's something that obviously is like the more data that comes out, the more we have the potential to not just treat, but also potentially, I hate to use the word cure, but for some people, once they're able to like process some of these blocked like trauma and emotions, they may be able just to move on with their life versus having to be on lifelong therapy. So there's, of course, there might be government support for that, and there's going to be pharmaceutical company pushback on that too, right? So we're kind of in that world of like, is it like, how's it going to go? But yeah, as of right now, I'd say it's mostly private to really do it properly. But there may be ways to access funding through employer benefits or other means.
Excellent. I don't see any other questions coming in. We are just past 8 o'clock. So I think what I'll do is I'd like to thank everybody for attending the session tonight. And I do want to echo some of the comments I've been getting in our chat. Very informative, really appreciated. Thank you so much. I think this has been a wonderful, wonderful session. So thank you, Candace. I think it's just really interesting to have the discussion on some of these emerging therapies for PTSD. End of life therapy with the psilocybin also was super, super interesting to hear about
Mhm.
that. So I also want to thank the Mental Health and Addiction Center of Excellence at Ontario Health for sponsoring this program. And once again, thank you so much, Candace, for coming by and sharing all of your knowledge and experience on this topic. So thank you.
Thanks so much. Thanks, everyone. Have a great night.
Great night. Take care, everybody. Bye bye.